I have a lot of slides, and so I'm just going to get as far as I can before someone tells me that I have to stop. And so I'm going to go from there. Okay, so the idea here is I'm going to very quickly review some of the things I said yesterday, including what the Pentad is, the grading system, and actually expand upon that from yesterday, the embryology and natural history of the Pentad, and learn clinical treatment pearls, or teach some clinical treatment pearls, and then some unique methods of assessing patients that have this issue. So very quickly, just to remind everybody, the Pentad super syndrome, basically the combination of 5 entities, dysautonomia, mast cell activation, Ehlers-Danlos, eventual autoimmune disease, and then the 5th one, gastrointestinal dysmotility, is really a combination of the other 4 working together to cause problems in the GI tract. And the idea of thinking of things in the terms of the Pentad is to take this chaos of all these sub-syndromes that you've heard about in lots of different settings and put it into a meaningful context that's a little bit more workable, particularly for the patient and the provider, so that you're not just working with trying to decide how to manage and understand what I think is just chaos when you don't think of it this way. And so when you put it in the terms of the Pentad, all these sub-syndromes suddenly start to make a lot of sense. For instance, patients who don't show up with a lot of evidence of Ehlers-Danlos, you really shouldn't be thinking of all these sub-syndromes over here. And patients that don't show a lot of mast cell activation syndrome, you really shouldn't be spending your time thinking about these syndromes over here, and so forth. So it kind of gives you a heads up what to look for and what is probably not something worth pursuing if you don't have a major portion of the Pentad there. Okay, so yesterday I touched on this idea of functional grades of dysautonomia, and I find this very, very helpful in really categorizing patients to decide how much workup they're going to need and how much therapy they're going to need. And so there's a system that it follows very closely with the New York Heart Association grading for congestive heart failure. And the idea here is that it's 0 to 4 as far as the functional grades. 0 is no symptoms at all. Grade 1 is mostly asymptomatic and usually just the symptoms that a normal healthy teen would have, such as having vasovagal symptoms. If you think about vasovagal syncope, you say, well, that's a normal thing, but it's also not really the intention of the organism to lose consciousness upon standing. And so it really is an autonomic dysfunction, but it's within the realm of normal for a developing teen. Grade 3 dysautonomia is where you have daily and nearly constant symptoms that involve multiple organ systems that interfere with school or work, sports, social life, but don't require any medical devices. And grade 4 is just a little bit higher than that, where you're so sick that you depend on medical devices, PICC lines, ports, G tubes, GJ tubes, wheelchairs, being bedbound. And then grade 2 is kind of this gray area between just being a normal, healthy young person and things that are interfering with school, social life, and sports. And the idea of the pyramid here is to kind of help suggest the prevalence of the disease and the severity of the symptoms. But really, grade 1 is by far the most common, where even grade 0 is not that common in a young person. And POTS is kind of just right there, this what I call a nebulous cloud that's overlays grade 3 and 4. And POTS, of course, is this type of dysautonomia that also includes a heart rate rise upon standing, 30 points if you're over 16 and 40 points if you're under 16. But to me, I think of it as a nebulous cloud that fits with dysautonomia. That's not a separate category. A lot of my colleagues, particularly neurology colleagues, think of it as a separate entity from the other entities they describe. And I don't think of it that way. And I have this nebulous border because it's not that hard to take a patient. In fact, even the patient themselves has good days and bad days where they'll have a 30-point rise on some days and nothing particular different about them. They come in and will not have that 30-point rise. And so they're in and out of POTS criteria just on a day-to-day basis. And certainly I can give a beta blocker or some other medicine that hampers their heart rate rise and suddenly take them out of the POTS criteria, but haven't necessarily made them any better way, shape, or form. And so I don't think of POTS as such an important designation that other people do. And then at the top of this pyramid, you've got the grade 4, and this is where you have a lot of different very serious things going on to make a patient extra sick. Now, if you take these functional grades and take all young people, say 9 to 25 years of age, the typical time that they'd be having grade 1 dysautonomia, if you put them all into this pyramid, the biggest grade that they have is grade 1, as I said before. Very few are down here in the grade 0. And again, as the severity of the symptoms go up, the prevalence goes down. And if you subtract out all the boys and just leave the girls, there's a gravitation toward the sicker end, and that's the effect of estrogen being a powerful vasodilator, and that cycles in a body that's not used to vasodilators cycling on a monthly basis. And so girls oftentimes will have a lot more dysautonomia type symptoms than boys. So boys gravitate toward the healthier end. Then you add in the patients that have hypermobility and Ehlers-Danlos type of findings, and they tend to gravitate really high up in this system. All right, so I'm going to talk a little bit real briefly about embryology of the Pentad just to set up for the rest of the talk. I mentioned yesterday there's a lot of ways to enter into the Pentad, but everybody circles the same drain in the end, essentially, for the most part. So it doesn't matter whether you have a primary vagus nerve dysfunction, and again, the kind of the classic of that would be someone who has a concussion and then their whole world changes after that. Or a primary mast cell derangement where very early on as a child they were already having food sensitivities and very hyperallergic. Or a primary GI derangement where very early on they were already complaining of abdominal pain and other motility issues. Or maybe very early on, the very first thing that was happening was hypermobile issues. So there's a lot of different ways to enter into this drain, but everybody ends up circling the same drain for the most part. And again, as a cardiologist, at least early on, before I started seeing all comers from all walks of life, I was seeing a lot of primary vagal nerve dysfunction. So I understood this pathway better than the others. I understand the other ones, I think, just as well at this point. But just to give an example of what I call the clinical phases of the development of the Pentad, if you were to start with just a pure vagal dysfunction phase, you see patients going perhaps over a couple of years' time through these phases, a pure vagal dysfunction phase, followed by shortly after by what I call a renal hypovolemia phase, into what's called a metabolic dysfunction phase, where kind of everything goes awry in all directions of the body in the metabolic dysfunction phase. And then finally, this phase 4, which is kind of a consequence of the metabolic dysfunction phase, which includes showing autoimmunity showing up and structural changes in the body showing up. So if I go back to this idea of the triangle here, the pyramid with the grades, and I turn that 90 degrees and look horizontally through time and line up all my young people here from the day they're born, you can see everybody's marching toward this wall of dysautonomia. And for the most part, people go through grade 1 dysautonomia, and then through their teens, they come out the other side with their grade 1 dysautonomia resolving. And so those who are having head rushes upon standing up, or feeling fatigued, or occasionally fainting in different circumstances that you would call vasovagal syncope, they grow out of it. And that's the majority of people. And some are even lucky enough not to have any symptoms at all as a teen. But there are those up here who are going to be marching in, just because of their constitution, going to be marching into grade 1, then grade 2, then grade 3, and some even into grade 4 dysautonomia. And then you overlay the fact that some of these are going to march right into development of mast cell activation, blossoming in their hypermobility, and even into eventual autoimmunity. And again, not everybody presents this way. These are the patients that are typically starting off with a pure vagal dysfunction that marches in this direction. But sure, there's plenty of patients that start off with primary mast cell as the first thing, and primary hypermobility as the first thing. Primary autoimmunity is the first thing. So again, this is the natural course of those who start with a dysautonomia. But it kind of helps people understand that in a young person in the midst of their early illness, that pentad often looks like this, where dysautonomia is overwhelming issue. And there's just a little bit of mast cell going on, maybe a little hint of hypermobility, some gastrointestinal dysmotility going on, and maybe not even any autoimmunity showing up in any way, shape, or form, even with all the extensive testing you can do. And this is important because when I talk to my colleagues who see adult patients, we have a very different experience. And I think what's happening is, as you get later on in those years, that dysautonomia starts to dissipate for the most part. And mast cell and Ehlers-Danlos and GI dysmotility and autoimmune starts kind of taking over as the major issue. And if you remember the natural history that I showed you, you can start to understand how dysautonomia becomes a little less of an issue than the other things. And that's partly because blood vessels in a young person are so healthy and so dynamic and dilate so easily, and the baroreceptors are so healthy and so sensitive that they overreact. And when they overreact, it can cause a lot of vasodilation. It can cause a drop in the heart rate that's pretty dramatic compared to an older person. And I liken it to young people being like a high-performance sports car. They're like Ferraris, and there's something wrong with like the fuel injector stuck on overdrive, on wide open. And so a high-performance sports car is going to behave wildly if it's not working quite right. Well, as you get a little bit older, you're kind of shifting from a high-performance sports car to, a simpler, Mazda or a Jeep or something like that. And so some dysfunction in the system isn't quite as dramatic. Okay? So I like the idea of the natural course of the pentad to explain what the goal is here as someone who's treating patients. You're trying to deflect them down. You're trying to deflect them into a new natural or new course. And so it may take some dysautonomia therapy to deflect them down a little bit, and then maybe some mast cell therapy to deflect them down even further, and then they can hopefully pop out of this in a different way. And so you're not necessarily going to be following this route here just because you have a genetic predisposition to it. So. All right, I mentioned yesterday the idea of where the vagus nerve could potentially be injured in those patients who have a primary parasympathetic dysfunction. And I mentioned how it's a combination of, it's usually the parasympathetics that are dysfunctional, particularly the vagus nerve, and that usually the sympathetics have to try to compensate. The nerve terminus of the vagus secretes acetylcholine, And this is oftentimes the issue with patients with dysautonomia. So now I'm getting to the part where I'm adding some new stuff here. I've labeled these things little clinical pearls to highlight, this is what we think about when we're treating patients with dysautonomia. So if acetylcholine synthesis is impaired and there's a paucity of acetylcholine for one reason or another, then it makes sense that we use a medicine called Mestinon, pyridostigmine, to enhance acetylcholine. So that prevents the breakdown of acetylcholine and allows larger amounts of acetylcholine to appear within the gap junction here. I've had a lot of success also putting patients on the supplements choline and pantethine, and if you look at the pathways of production of acetylcholine, there's the choline there, but pantethine also is added into this to form acetylcholine. And so if you use somewhat large quantities, macro quantities of choline and pantethine, you can actually get some of the same effects you see with Mestinon. And you can use them together and get some of a synergistic effect. And I've got a couple slides near the end that actually show how this is effective. So the idea here is you're using these medicines when you have a patient that looks like they're struggling to form acetylcholine, and oftentimes that is the typical POTS symptoms, but certainly racing heart and GI dysmotility would be clear times when pyridostigmine and choline and pantethine would be used. As I said yesterday, the main, at least from a cardiovascular standpoint, one of the main consequences of having vagal dysfunction is a redistribution of blood flow improperly, such that gravity is able to pull blood downward and the body doesn't appropriately compensate for that. And so not only do you have an issue with not enough blood flow getting to the head, but you got blood pooling in the lower half of the body. Okay. And one of the consequences of that, blood pooling in the venous system, actually struggles to fill the heart. And so if it struggles to fill the heart, then the body tries to compensate by increasing its heart rate to keep the cardiac output up, but usually it still fails because if the ventricles if the blood's not there to fill the heart, it doesn't matter how fast the heart goes, the cardiac output is still going to drop. Body tries to compensate for that as best it can by revving up the sympathetic nervous system, secreting a lot of acetylcholine. And the consequence of that is a lot of anxiety, racing heart, palpitations, insomnia. And so that's the consequence of this sympathetic overdrive. So trying to manage that is with things that slow down, really block this. So beta blockers are helpful with that. You have to be careful not to give too much because you don't want to drop blood pressure in a patient that's already got a tenuous blood pressure. You're potentially going to cause increased fatigue, dizziness upon standing, fainting if you push the beta blockers, so you can only use a little tiny bit. Clonidine and guanfacine are both alpha blockers, so you really don't want to just block the beta receptors. You want to block both the beta and alpha. Again, all of that lowers blood pressure, so combining these together is very, very tricky and usually requires midodrine and fludrocortisone as what I call a base. Before you can consider these medicines, you really got to beef up their blood pressure a little bit with some midodrine and fludrocortisone. I'll talk about those in a minute. So another little clinical pearls. Within the beta blocker categories, I've listed all the typical beta blockers that are used, and I think the important things to consider when you're selecting a beta blocker, how selective they are toward beta 1 versus beta 2, how long they last, and what their metabolic pathway is for being metabolized. And if you look at all of these, I think it's really important to suppress sympathetic overdrive with a non-selective beta blocker, one that blocks both beta 1 and beta 2. And I like longer acting medicines. I heard yesterday mention the shorter acting is better, and I think that's only true if you are pushing the dose and you're pushing it such that the patient then can't exercise because they can't raise their heart rate with exercise. And typically, I think if you're giving that much beta blocker to a patient, you're already causing other problems with them. And so you really want to use less beta blocker, and then you're not going to be suppressing the heart rate rise with exercise. And then finally, the metabolism issue. At least 10% of us have a deficiency in what's called CYP2D6. You know, this is a metabolic pathway in the body that metabolizes a lot of medications, and CYP2D6 is one of the most important ones, particularly with the medications we give in treating the Pentad. So if you look at all these characteristics, one medicine really stands out better than all the rest, in my opinion and in my experience, and that's Nadolol. It's both beta 1 and beta 2, and it lasts a full day. You get a nice, even blood distribution, and you don't have peaks and valleys through the day. And it doesn't require any liver metabolism or any metabolism by the body. So it doesn't matter whether you're a 2D6 deficient patient or not, you're going to be able to handle Nadolol. And I've switched a lot of patients coming into my practice who's been put on propranolol. I used to use a lot of metoprolol and realized, yeah, that's great for suppressing heart rate, and it's pretty good for migraine headaches, but it didn't suppress anxiety. It didn't stop. It didn't help with insomnia. So I realized you really got to suppress some beta 2. Again, you have to use a small amount because, beta 2 receptors are in the lungs. And if a patient has a propensity toward asthma, then you might be bringing that out. But usually, using 10 milligrams a day, which is half of a tablet of the smallest tablet, is usually what does the trick. Sometimes a full tablet, 20 milligrams. But for most patients, a very small dose of Nadolol once a day will take away migraine headaches. It will reduce their racing heart. You may need a second medicine, but there are plenty of other medicines to add to control the racing heart. So that's my clinical pearl on beta blockers there. Yes, when you have dysfunction, you've got a racing heart, and beta blockers, particularly in low dose, don't always do the trick. So that's when you add IVA Braden. IVA Braden has been fantastic with slowing down racing heart. It's been fantastic for increasing energy, reducing fatigue, reducing dizziness upon standing. The interesting thing that I find with IVA Braden that is not described anywhere, the only side effect I ever get with that is vertigo. So I don't know where that's coming from. I don't know why it's not described, and it doesn't seem to be in the congestive heart failure population, but it certainly is within the dysautonomia population. And it can be dose dependent, where I'll push the dose. I'll start at 2.5 milligrams, which is a half a tablet, twice a day. And patients may do fine on that. They may do fine on a full tablet twice a day. Push them to 7.5, they start to get vertigo. And every patient has their cutoff for when they're going to start to develop vertigo. I may have to back them back down to 5 or back them back down to 2.5. I may have a very rare patient, even on 2.5 twice a day, where they'll get vertigo and just can't tolerate IVA Braden. But it's interesting that none of the other complications from vertigo, from IVA Braden I've seen, and only vertigo. And then finally, Mestinon or Rivastigmine. And complications from that would be, if you already have a very good motility to your GI tract, you're going to cause hypermobile activity. So that's where that's usually limited. I've had a patient or two actually have a bleeding diathesis from it. So it's described that Rivastigmine can cause increased bleeding, so nosebleeds and things like that. So you have to take them off in that case. I have, by the way, I didn't put that on here. I should have. I've used Rivastigmine in place of pyridostigmine, and it seems to work as well as pyridostigmine in calming a racing heart and all the things you would use Mestinon for. But when a patient doesn't have a functioning GI tract and they can't take oral medications, the rivastigmine patches are good alternatives. The limitation there is a lot of patients have mast cell activation, so they don't respond well to having a patch on their skin. But it's a definite alternative when patients don't have reliable GI tracts to use rivastigmine. I mentioned yesterday about phase 2, the renal hypovolemia phase, and the kidneys getting into the act of thinking that you're fluid overloaded. They're doing their job. I've had some patients come to me yesterday after the talk to say, well, then the kidneys are dysfunctional. And like, no, they're doing their job. They are exactly doing their job. They think that there's too much volume going to the kidneys because of this flow distribution problem. So they're acting appropriately and diuresing what they interpret as fluid overload. But that's not what we want, and we need the kidneys to knock it off. So fludrocortisone, that's the role of that we use fludrocortisone for. It raises the bar for what the kidneys sense and diurese at a different level. So you're actually able to hold some volume with that. And I include licorice root here because licorice root has ingredient within it that basically is an aldosterone type drug. And so some patients who want to stay natural will use licorice root. In my opinion, it actually is just as dangerous and fraught with just as many complications as using the synthetic fludrocortisone, plus it's not very well regulated from dose to dose. So I've had patients come in on licorice root that have wild swings in their blood pressure from day to day, and when I switch them over to fludrocortisone, that evens out and they end up liking it better. Okay, I talked yesterday about this brain-gut vortex that explains how mast cell activation gets into the picture of dysautonomia, and eventually how that leads to other things, which I'll show slides of too. But if we talk about mast cell activation syndrome, I mentioned how I believe elastase 2 is a huge component of this. Dr. Chopra had talked today and yesterday about the idea of biopsies, looking for mast cells in the GI tract, and I agree with him that all the other lab tests are completely unreliable because of how fleeting all the substances are that we're looking for and how difficult the handling is. I think that, where I am, it's even more so. I think that, all my colleagues out on the West Coast struggle to ever get a positive test back because of how far it has to travel to get to the laboratories that test for everything we're looking for. So I routinely, one of the questions I always get on my patients is, have you ever had a GI biopsy? And I will track down biopsies from when they were infants. And, any time, sometimes they'll have 3 or 4 biopsies over their lifetime before they get to me, and I'll try to track down every one of them to try to show that there was a progression in the mast cell number. And I find all the time that these patients that never showed any other laboratory tests for mast cell will have increased numbers in mast cell. And this is an increased number here. This is probably on a high power field showing around 25 or 30, but I've had patients in the 90s and 100s for their mast cells per high power field. And those are patients who were never diagnosed. The biopsies were reported as completely normal. Typical number, very little studies that show what a appropriate number is, but we usually quote 13 plus or minus 6 as the number. So we say the cutoff is 20 for anything above 20 is abnormal. And this is well above 20 per high power field. I also now do this thing called a Kesey chemical sensitivity questionnaire as a way to have kind of a heads up on how bad a person's mast cell disorder might be. This is something started by Claudia Miller. You can look online, the Kesey Questionnaire, and you can actually fill out your own online, and it'll produce a nice little graph like this, and you can even forward it to whatever provider might be interested. I always have my patients forward their results to me so I can include it in their chart. The larger this circle, outside the gray circle, the more likely they have a mast cell component to their illness. So that's one of the questionnaires I have every patient fill out as they're coming in to see me for the first time. Okay, here's another little random clinical pearl here, but since we're talking about mast cell, I like to think of mast cell activation syndrome like bees in a beehive. And maybe that's because I have bees myself. I keep bees, and so think about this in these terms. But, if you think of the GI tract as the entrance to a beehive, and if you have happy bees in the entrance of the beehive, then you're going to have happy bees throughout the hive usually. But if you introduce some threat to the bees at the entrance of the beehive, it doesn't take very long before the entire hive is angry. And I think that's what happens with mast cell activation syndrome. Whether it's the GI tract or the skin or the nasal mucosa, wherever that entrance is for a person with mast cell activation, you aggravate those mast cells, and there's the components that are released from the mast cells in that area are acting like pheromones the way bees would release pheromones, aggravating bees in the entire hive. And so it may have started in the GI tract, but it takes no time at all for the mast cells around the meninges in the brain to be aggravated and causing sometimes an explosive headache after they have been exposed to something that stimulates their mast cells. So that's how I like to explain how mast cells are aggravated throughout the entire body. And then the other clinical pearl along these lines is what I call the bicycle tire theory of mast cell activation treatment. And that is, patients come in and say, Dr. Maxwell, if you're right that there's a mast cell component to what's going on, then maybe I'll just take some Zyrtec, and if I don't get better, then you're not right. And I say, no, you got to think of it as a bicycle tire with 8 holes in it. And you can't just patch one and think you're going to get anywhere. You got to patch all 8 holes. And the holes are, the histamine that comes from food and bacteria. SIBO produces a lot of histamine or aggravates the GI tract. There's the histidine decarboxylase. There's diamine oxidase in the body that produces and breaks down histamine. There's the elastase 2 that I talked about yesterday. That's a big issue. There's the leaky gut that comes from all that. There's mast cells that are increased fragility. And then there's H1 and H2 receptors that are perhaps more sensitive, higher density, that need to be managed. So you got to patch all 8 holes if you're going to do anything, and that's with a low histamine diet, getting rid of any SIBO, usually with probiotics, betaine, to do that, restoring the methylation folate pathway. I explained yesterday why I think that's important. Blocking elastase 2, I've got a little slide on that later. Giving L-glutamine to help repair your leaky gut. Stabilizing the mast cells both systemically and in the gut. Dr. Chopra explained how that's often done. H2 blockers and H1 blockers. So I usually will just go ahead and put a patient on multiple medications and supplements and get them on a really healthy diet to block that. I mentioned yesterday how I think elastase 2 is kind of at the center of getting you onto deep into phase 3 and onto phase 4, breaking up cadherins. And so being able to block those would be really important, because I believe phase 4 arrives simply because of this effect of mast cells. So autoimmunity and what I call viscerotosis, or sagging of your organs. That's a big part of Ehlers-Danlos. And there are a couple of supplements that actually block elastase 2. I've put patients on these when it seems that their Ehlers-Danlos is really getting out of control. I have to admit there's not any data yet that shows that it's altered the course of their illness, but it's something that I hope to be able to look at some point. Horse chestnut seed extract and indole 3-carbinol are two supplements that can be purchased, and so I'll put patients on that to see. This is particularly patients who are really blossoming with their Ehlers-Danlos and ribs popping out on a daily basis, moment-to-moment basis. Then I'll put them on this to see whether I can change that, because it seems that that's at least something that is almost measurable as opposed to everything else. And it's too early to say whether this is going to be effective or not, but just to give you an idea of the kind of thinking that is. And the other thing is putting them on L-glutamine, because L-glutamine has a very specific pathway in the body for stimulating the production of new cadherins. So when your doc or dietitian recommends that you be on L-glutamine for the leaky gut, it's not just a throwing something at you. It has a very specific pathway that's restoring these little gap junctions here, restoring the tight junctions. All right, so I'm going to talk I don't know, how far can I go? Yeah. Okay. All right. Well, I mean, I've got all these different strategies I do to make the process of assessing and caring for patients better. Jill Schofield and I came up with something called a dysautonomia quotient, which is basically a questionnaire that they have to answer every time they come and visit me. This is the front of the paper copy and the back of the paper copy, but we have an online version where they can go on their phone on the way in and point and click and check off boxes, so they, as their parent is driving them into the clinic that day, or they're waiting in the waiting room, they can do this, and then we put it into the chart, and it really, really helps me. What it does is it scores them. It gives them a functional score, 0 to 100, where 100 is as sick as you could be. And then it gives you subscores of general, cardiovascular, GI, GU, and neuro, and that's on a scale of 1 to 25. And so a typical score would look like, 50, 12, 6, 7, and 10. And, I know where to focus. I know whether I've made them better or worse from the last time they visited me. And the breakdown of all the questions, what category they belong to are there. And we've validated it. It'll soon be published. Validated against the Compass 31, which I don't know if anyone's ever filled out a Compass 31. It doesn't make a whole lot of sense as far as visit to visit, because some of the questions are kind of permanent questions, not from last visit type of questions. It correlates pretty well with it, but I think gives better information about visit to visit information. And then you can put those scores. I've over 500 or so patients sampling we have, where we have the average score depending on what your functional grade is. So, a perfectly healthy person could still score, a 9. Grade 1, score 12. Grade 2, 27. Grade 3, 39. Grade 4 in the 50. The highest score I have is around 88, and they're pretty sick. You've seen how we do the lying, sitting, standing blood pressure and heart rate. You've heard about tilt table testing. Perhaps you guys have heard about QSART as a test. I don't do that a whole lot. My neurology colleagues do this more. The electromyography is another thing to do that the neurologists often do. But what I do, yes, EKG, yes, sonogram, but I put on this thing called a cardio key. And the nice thing about the cardio key is it gives you heart rate variability. And so these Poincaré graphs are very, very helpful in determining how much better I've made their palpitations. Basically quantitates their palpitations. And Poincaré graphs can be interpreted, this RR interval. If you've got something very constant here, then it's going to fall along this 45-degree pathway. If it's variable, then it's going to be points off to the side. So this is a normal, healthy person's Poincaré graph. and then Poincaré graphs worsen in correlation with their functional grade. Where you can see over here, grade 4, their heart rate variability is all over the place. And their heart rate rhythm strip may look like this. And that's really what patients are feeling when they're describing palpitations and racing heart. I can put monitors on them, and maybe they're 10 points higher on average than what you would expect for their age, but it's not impressive. A cardiologist would not be impressed at all with their average heart rate for someone who's complaining that their heart's racing all the time. But I think 10 points higher on average is enough to make a person feel uncomfortable. And more importantly, it's what their variability is doing. And when I correct this variability, their heart rate may not even come down all that much. It may be like a 10-point drop after putting them on IVA Braden and beta blocker, and their heart rate over the course of 3 days, which is what I usually look at with these, is not that impressively less, but their variability will be less. And here's some examples. Here's someone before and after choline and pantethine, before and after choline and pantethine, before and after choline and pantethine. So this kind of shows that, yeah, choline and pantethine really does work to reduce variability. And here's Corlinor, before and after Corlinor. And here's this heart rate average. It went from 98 to 97. Patient felt a heck of a lot better. They stopped complaining of palpitations, but their heart rate average over 3 days went from 98 to 97. And you can even look at their highs and lows, and it didn't change all that much. Here's before and after Corlinor. Went from 76 to 66. You know, really, they're complaining of racing heart when their average is 76? Yeah, they were complaining of racing heart, and they only went down to 66. And this is what I think really changed, was their variability. Same here. This patient was just on choline and pantethine, and then we added mast cell activation stuff and reduced their variability. So here's histamine or some other component within the mast cells causing the heart rate variability, causing them to feel like they had palpitations. We corrected it with anti-mast cell stuff. I exercise patients, and a lot of information comes from this. This, to me, is my tilt table testing. It gives a lot of the same information that a tilt table test would be. We do pulmonary function tests to make sure their lungs are looking okay. Everyone complains of chest pain and shortness of breath, and you know, this is what we usually find, is actually their lung function is not all that bad. But their heart rate is pretty high just sitting on the bike. And it goes off the charts sometimes. And then the duration is less. And here's someone after treatment. Their heart rate's down less, they last longer.